Assalamualaikum and salam sejahtera. My name is Humaira binti Ifan Hanuddin. We from group D3, we present about hard work. This is my group members, which is Maulana Priya, Muhammad Nabi Aiman and Farhan Wakiuddin. The question that we got is, bioprocessing valve is an artificial heart valve made from person involving heart tissue. Calcification is the most common cause of damage and subsequent failure of bioprocessing heart valve. First, Roman, describe the factors that contributing to the development of calcification. There are 6 factors, which is first, tissue residue. Glutaraldehyde fixation lead phospholipid and cell debris act as calcium phosphate nucleation site, lead to hydroxyapatite crystal formation. Second, immune response and inflammation. Macrophages infrared valve tissue release MMP2 and MMP9 matrix breakdown, oxidize stress damaged tissue, new site for calcium to attach. Third one, lipid build-up. Oxidized LDL accumulates in valve, triggers inflammation, activates DMP2 osteogenic bone-like activity. Next, mechanical stretch. Constant opening and closing of valve, causing microtears and structural damage. This weak spot and calcify faster. The number 5 of factor is thrombosis and platelets. First, platelet activation on valve surface. Second, increase local calcium and concentration. Lastly, speed up materialization. And the last one is patient risk factors. First, from age, diabetes, high cholesterol, and valve position.
Preventing calcification in implant isn't just about medicine. Biomaterial strategies can make a big difference. Let's look at 3 key approaches. First, we have surface modification. This means altering the implant surface to reduce calcium buildup. Technique like plasma treatment or chemical grafting add anti-calcific group like carboxyl or phosphoryl to the surface. Coatings such as PEG or Zwitter ionic polymer also help by reducing protein and cell attachment, which are early triggers of calcification. Second, we can incorporate anti-calcific agents directly into the material. Substance like magnesium ion, phosphoricitate, or EDTA interfere with the crystal formation or bind calcium ion to prevent mineral deposit. This internal chemical resistance is especially helpful for long-term implant. Third, using flexible polymer like polycarbonate urethane or silicon rubber help reduce mechanical stress, which is another cause of calcification. These materials are more durable and less likely to trigger inflammation. Even smart design tweaks like reshaping heart valve leaflet can reduce stress and lower calcification risks. In short, by modifying surface, embedding anti-calcific agents, and using flexible material, we can design implant that resist calcification naturally without relying solely on medical treatment.
Next, I would like to go for question 3, which is conduct the biological evaluation of the bioprosthetic heart valve as part of a risk management process based on ISO 10993. Biological evaluation of medical devices, Part 1, which is evaluation and testing within a risk management process. Your analysis should contain medical device categorization, nature of body contact and contact duration, and biological evaluation tests required for the device. Medical device categorization and biological evaluation tests required for the device. Device categorization. Type: implantable, indirect blood contact. Duration: permanent, more than 30 days. Risk level: high risk cardiovascular implant. Risk based on approach. Follow ISO 14971 risk management process. Start with material analysis and chemical categorization ISO 10993/17/18. Reduce unnecessary testing if sufficient data is exists. Second is the required biological tests, cytotoxicity, cell healthy and viability, sensation and irritation, immune and allergic responses. Systemic toxicity is for acute to chronic toxicity. Implantation testing is for tissue response to device. Genotoxicity or carcinogenicity is for DNA and cancer risk. Hemocompatibility is for hemolysis and inflammation. Scientific justification. Glutaraldehyde fix the tissue and polymer required for extractable testing. Surface coating such as polymer will reduce the classification and thrombosis.
Assalamualaikum warahmatullahi wabarakatuh, and hi, my name is Farhan Wakiuddin. Today I will be your junior biomedical engineer leading the development of our new bioprosthetic heart valve. First, we have the main component of the valve include the first one is leaflets, second stem, and third is sewing cuff. Okay, we move to the first part is leaflet. Leaflet is the function to regulate unidirectional blood flow. Usually, the material is porcine aortic valve tissue, bovine pericardium, or polymeric materials. We move to the stent, which provide structural support and shape retention. The usual material is stainless steel, cobalt chromium alloy, or nitinol for self-expanding valve. Third, sewing cuff. It facilitates suturing of the valve to the native tissue. The usual material is polyester dicron, polytetrafluoroethylene, which is PTFE. Okay, we move to the second part, which is design consideration. We must address three key properties. First, chemical properties. Material must be highly biocompatible, avoiding immune rejection or inflammation. They should also be non-toxic and withstand sterilization method like ethylene oxide or gamma radiation. Calcification resistance is critical because calcium deposit can stiffen and damage the valve. And the second part is morphological properties. The valve surface topography should encourage healthy cell lining. For example, nanostructured surface help reduce platelet adhesion, lowering the risk of blood clot. If tissue engineering is used, porosity in the scaffold must allow nutrients and cell to move through, ensuring tissue integration. Okay, we move to the third part, which is mechanical properties. Durability is key. The valve will open and close about 100,000 times every day, or over 200 million cycles in a lifetime. It needs excellent fatigue resistance and tensile strength, matching native valve tissue around 1 to 2 megapascal. Good compliance and flexibility will let it mimic natural valve motion, reducing the risk of thrombosis or regurgitation. We aim for a valve lifespan of at least 10 to 15 years. Firstly, sewing cuff. I propose woven polyester or dicron due to its high suture retention strength and slightly porosity, which promote tissue ingrowth for secure fixation. Second, stent. I recommend nitinol, a nickel titanium alloy with super elastic properties, perfect for self-expanding valve and exceptional fatigue resistant for millions of cycles. Okay, third, leaflets. We propose glutaraldehyde treated bovine pericardium is ideal. It has proven clinical performance with up to 20 years of durability, high tensile strength, flexibility, reduced immunogenicity, and lower rates of calcification compared to untreated tissue. By combining this material and design consideration, we can create a safe, long-lasting bioprosthetic heart valve that closely replicate natural function. And so, thank you.